Chapter 42, Antihypertensives. When discussing hypertension, let's begin with the regulators of blood pressure. That would be the kidneys, the hormonal balance, catecholamines, baroreceptors within the aorta and carotid sinuses, the vasomotor center of the medulla, and hormones like ADH, ANP, and BNP. For physiologic risk factors, these are going to be mainly lifestyle, excess saturated fat and simple carbohydrates, alcohol that increases renin secretions, obesity that increases cardiac output, stroke volume, as well as left ventricular filling, some different cultural responses to hypertensive agents, and the normal hypertension that occurs as we age and our blood vessels lose that elasticity, that stretch during contraction. Non-pharmacologic control is going to deal with things like stress reduction, exercise, salt restriction, decreasing alcohol ingestion, and smoking cessation. One common first-line treatment is going to be diuretics, thiazides such as hydrochlorothiazide, and loop diuretics such as furosemide. And what these two have in common is that they flush out potassium along with the excess fluid. So when a patient is on a thiazide or a loop diuretic, we're going to expect their potassium level to decrease. On the other hand, there is potassium-sparing diuretics, such as spironolactone or aldactone. And these actually cause fluid excretion while blocking the excretion of potassium. So we're going to be expecting the patient's potassium level to rise. Sympatholytics, these are things like beta-adrenergic blockers, essentially acting alpha-2 agonists, alpha-adrenergic blockers, adrenergic neuron blockers, as well as alpha-1 and beta-1 adrenergic blockers. In the case of beta-adrenergic blockers, these are non-selective beta blockers. They inhibit the beta-1 and beta-2 receptors, drugs like propranolol and carvedilol. They're also cardioselective beta blockers that mainly block the beta-1 receptors, such as atenolol and metoprolol. Side effects, again, bradycardia. We always going to check that apical heart rate anytime before we give a beta blocker. You also run the risk of side effects like hypotension, dizziness, insomnia, fatigue, nightmares, depression, bronchospasm, and erectile dysfunction. There will be a lot of older males that will refuse to take beta blockers because of this. Centrally acting alpha-2 agonists, such as methyldopa or clonidine. They work to stimulate alpha-2 receptors while decreasing cardiac output. They also decrease epinephrine, norepinephrine, and renin release while increasing vagus nerve activity. Methyldopa, this is going to be contraindicated during impaired liver function and would again have side effects like dizziness, drowsiness, dry mouth, headache, peripheral edema, and bradycardia. You should avoid abruptly stopping the drug as rebound hypertension may occur. Alpha-adrenergic blockers such as doxazosin, prazosin. These block alpha-adrenergic receptors and result in vasodilation along with decreased blood pressure. Side effects, things like orthostatic hypotension, tachycardia, headache, drowsiness, dizziness, nausea, edema, and weight gain. Adrenergic neuron blockers such as reserpine. These block norepinephrine release from the sympathetic nerve endings, resulting in a decreased blood pressure. Side effects, again, orthostatic hypotension. And this is something you're going to see a lot in these antihypertensive meds. And that the body is not able to quickly adjust to changes in positioning and blood pressure. So when they stand up, they will get dizzy. And this causes a major safety consideration for these patients. Other side effects would include things like peripheral edema, dizziness, drowsiness, hearing loss, suicidal ideations, and pseudo-Parkinsonism. Alpha-1 and beta-1 adrenergic blockers. We're talking about labetalol. This blocks alpha-1 and beta-1 receptors, with side effects hypotension, bradycardia, paresthesia, depression, nasal congestion, nausea, and again, erectile dysfunction. Whenever we're giving beta-adrenergic blockers, we want to focus on perfusion and obtain a thorough medical and herbal history from the patient. We want to know exactly what they're taking, both prescribed as well as over-the-counter and supplements. Again, we want to carefully monitor vital signs, making a priority on checking that apical heart rate, anytime we're going to give a beta blocker. Also, look at lab results such as BUN, serum creatinine. Do not abruptly stop taking, as rebound hypertension can occur. And also avoid over-the-counter drugs without first checking with a healthcare provider, as there can be a lot of interactions. In the case of alpha adrenergic blockers, get those baseline vital signs, and we also want to make sure we have an accurate weight for future comparisons, so we can quickly and accurately identify if any weight gain is occurring. Check daily for any fluid retention. Monitor that weights closely. Advise the patient to comply with the drug regimen. And inform the patient that orthostatic hypotension may occur, so stand slowly, sit up slowly. Hydralazine, minoxidil. These relax smooth muscles of the blood vessels, especially arteries, causing vasodilation. Side effects would include things like hypotension, reflex tachycardia, palpitations, headache, dizziness, edema, and angina. In the case of ACE inhibitors, we're talking about prils, enalapril, captopril, lisinopril. These inhibit the formation of angiotensin II and further blocks the release of aldosterone. Side effects are going to be a non-productive cough, fatigue, insomnia, headache, dizziness, tachycardia, hypotension, and angioedema. Keep in mind that some cultures and older adults do not respond to ACE inhibitor monotherapy. It's also going to be contraindicated in cases of pregnancy, potassium-sparing diuretics, and salt substitutes that contain potassium, as ACE inhibitors can cause a rise in potassium. Angiotensin II receptor blockers, ARBs, losartan, valsartan, irbesartan. These prevent the release of aldosterone and act on the renin-angiotensin-aldosterone system. Side effects would be things like dizziness, hypotension, headache, weakness, fatigue, hyperkalemia, and hyperglycemia. Direct renin inhibitor. These bind with renin, causing a reduction of the angiotensin I, angiotensin II, and aldosterone levels. Side effects include dizziness, pharyngitis, hypotension, peripheral edema, hyperkalemia, diarrhea, and gout. Calcium channel blockers. These would include drugs like verapamil, diltiazem, amlodipine, and felodipine. These work to block the calcium channels in vascular smooth muscle cells, promoting vasodilation. Side effects would include weakness, headache, dizziness, peripheral edema, fatigue, bradycardia, hypertension, pharyngitis, and rhinitis. For our first practice question, a patient's blood pressure is 128/82. Which of the following stages does the nurse place this blood pressure? That be A, within normal range, B, within the elevated range, C, within the stage 1 hypertension, or D, stage 2 hypertension. This is something we're going to talk about much deeper in MedSurg next term. The answer here is A, within the elevated range, as the classifications for hypertension are much lower than you would expect. Anything over 120 is considered an elevated blood pressure. Question 2. A patient is receiving an angiotensin II receptor blocker. Which does the nurse recognize as an angiotensin II receptor blocker? That be A, valsartan, B, amlodipine, C, captopril, or D, metoprolol. And that answer is going to be A, valsartan. Anytime we're dealing with an ARB, it's a sartan. A patient is receiving an angiotensin II receptor blocker. Which of the following is most important for the nurse to assess the patient? That be A, constipation, B, tremors, C, asthmatic attacks, or D, dizziness. And that answer is going to be D, dizziness. Question 4. An African American patient is being treated with initial monotherapy to control hypertension. Which of the following does the nurse expect the patient to receive? That be A, diuretics, B, angiotensin converting enzyme inhibitors, C, alpha adrenergic blockers, or D, beta blockers. That answer is C, alpha adrenergic blockers. Practice question 5. The nurse should instruct a patient to taper off medication gradually and not suddenly stop taking antihypertensives in order to avoid which of the following? That be A, rebound bradycardia, B, rebound tachycardia, C, rebound hypertension, or D, rebound hypotension. That answer is going to be C, rebound hypertension. Practice question 6. A patient with hypertension is ordered to receive an angiotensin-converting enzyme inhibitor. Which of the following does the nurse identify as a common benign side effect of this drug? That be A, hiccups, B, flatulence, C, abdominal distension, or D, dry cough? And that answer is D, dry cough. And for our final question, before administering the alpha-adrenergic blocker prazosin, which of the following is most important for the nurse to assess the patient for a history of? That be A, renal disease, B, refractory heart failure, C, hypertension, or D, benign prostatic hypertrophy? And that answer is A, renal disease. But anyway, that's all we got for this chapter. I'll see you in the next slides.